Thank you, Dr. Pai, for that introduction. First of all, I'd like to thank Dr. An Kiara, President, and Dr. Rishikesh Pai, the trustee of the Asia Oceania FIGO. I'm really happy to be here today to, talk about advances in endometriosis. So, So, if you look at fertility, endometriosis is an enigma, and we all know that numerous studies in animals, etc., has shown that its effect on fertility is profound. There is definitely loss of follicular pool, declining quality of the oocyte, and reducing endometrial receptivity. If you look at this diagram, the formation of the endometriomas results in a focal inflammation, and that results in structural destruction of the surrounding normal cortex, which causes fibrosis and loss of cortex specific stroma. And because of this, there's enhanced recruitment, and along with it, atresia and apoptosis. All this causes dysregulation of follicular genesis and results in low AMH and reduced growing follicles. In short, endometriosis causes burnout of the ovary. Secondly, is the declining quality of the oocytes. There is increased apoptosis seen in the ovary. There's dysregulation of the molecular pathways. Then even the granular cell steroidogenesis is decreased by the expression of P450 aromatase, which is low. The presence of increased oxidative stress status in the follicular fluid has recently been confirmed, and that causes, spindle disruption. But studies have shown, as this article in August 2024, 13,000 plus IVF cycles the data was obtained from the HFEA. These were patients of endometriosis, and there was no difference in live birth as compared to those patients with male infertility. Studies examining the aneuploidy and the euploidy rates also have shown the equivalent rates of euploidy in between patients of endometriosis and controls. What about the endometrial receptivity? We all know that the abnormalities of the utopic endometrium in women of endometriosis contributes to the implantation failure. Dysregulation of the progesterone receptors results in progesterone resistance, and autoantibodies to antigens in the endometrium may further disrupt the endometrial receptivity and implantation. But again, we have studies which show that high quality embryos transferred during a medicated cycle, there is absolutely no difference in results in patients with or without endometriosis. So, yes, we have to learn how to manage. So, what are the factors that we are looking at? The age of the patient is very important. If there's any previous surgery, the volume, the size of the endometrioma, desire for pregnancy, the AMH, symptoms, all these factors are taken into consideration when we plan the treatment of a patient of endometriosis. So, in a patient of endometriosis, how to protect her fertility? Now, if you have a patient who is adolescent or she's young and unmarried, I think early diagnosis is very important. The signs and symptoms should be picked up. Or sometimes, as I have seen in a couple of patients, the endometrioma was just picked up on a routine ultrasound. In these patients, suppressive therapy is required, especially when the cyst is lesser than 3 to 4 centimeters. Progesterones, preferably Dynogest, OC pills, GnRH analog. But GnRH analog is usually avoided in girls who are less than 16 years old, and also you cannot give it beyond 6 months to 1 year. The follow-up is very important. History, especially if she's complaining of pain, worsening of pain, and of course, imaging, that is an ultrasound, to detect recurrence earlier. Ovarian endometrioma is an enigma which we must understand properly. The prevalence is as high as 50% in women with endometriosis. There's reduced ovarian reserve due to damage of healthy ovarian tissue and mechanical stretch. This results in progressive reduction of the primordial follicles. But in spite of this, no difference is seen in ART results in women with or without endometriomas. However, women with larger endometriomas and bilateral endometriomas have a lower oocyte yield. But when you operate on an endometrioma, what happens? AMH drops by as much as 30% if you operate on a unilateral endometrioma. AMH drops by 44% in a bilateral endometrioma. And the risk of premature ovarian insufficiency is about 2.4% following bilateral ovarian cystectomy. So, surgery for endometrioma today is done only for symptom control or if there is no access to the ovary during an ovum pickup. So, I think it's important to remember, and we will be covering it in our next slide. Now, these patients, as I said, protect her fertility. Oocyte vitrification is one more technology which can empower the girl and can protect her fertility. The earlier the girl performs oocyte vitrification, better are the results. Patients with endometriosis should therefore be counseled to do a fertility preservation at a young age, preferably younger than 35 years. Patients should also be encouraged to freeze before surgery. 10 to 15 eggs in a less than 35-year-old. The clinical live birth rates are about 40 to 70% in a research paper by Anna Cobo et al. Adult women who are not married can freeze embryos. And of course, ovarian tissue cryopreservation is also seen in a few patients, but these are very few patients because you don't want to put her into HRT. So those people who cannot avoid surgery and there is no time for egg freezing, those are the patients where the ovary is frozen. Ovarian tissue is frozen. Sorry. So endometriosis fertility index is a very important milestone because there are a lot of, I always have an argument with the endoscopic surgeons saying that, oh, once we do endometriosis surgery, she definitely conceives. You don't need IVF. But I think we need to put it according to the data which is available. So if you have operated on a patient, calculate her endometriosis fertility index because that will optimize the management of this patient. Women with a very low EFI, less than 4, have just 20% chance of spontaneous pregnancy after 1 year of trying, while those with the EFI of 7 to 8 have a 40 to 45% chance. So obviously, the ART will give you a better pregnancy rate than 20%. So this is how we can actually decide if the patient can be left alone to try spontaneously or she should go for IVF. So the ESHRE guidelines, which were released in 2023, are really very clear, though of course the evidence is not that strong. But in stage 1 and stage 2 endometriosis, if they're undergoing a laparoscopy prior to treatment with ART, then clinicians may consider complete surgical removal of endometriosis to improve live birth rate, though the benefit is not well established. But remember, if you're not planning a laparoscopy, that's also fine. But if you have done a laparoscopy and you see mild endometriosis, please treat it. Then, of course, the deep infiltrate, DIE, the effectiveness of surgical excision of deep nodular lesions before treatment with ART in women with endometriosis-associated infertility is not well established. So it is not recommended to these patients prior to IVF. What about the endometrioma? In infertile women with endometrioma larger than 3 centimeters, there is no evidence that cystectomy prior to treatment with ART improves pregnancy rate. So today, the decision is that if the endometrioma is less than or larger than 3 centimeters, surgery should not be done. Only if women with endometriomas, which are larger than 3 centimeters, the GDG recommends clinicians only to consider cystectomy prior to IVF is to improve endometriosis-associated pain or the accessibility of follicles. I think this is a very important fact to remember. And the GDG recommends that clinicians should counsel women with endometrioma regarding the risks of reduced ovarian function after surgery and the possible loss of the ovary. The decision to proceed with surgery should be considered carefully if the woman has had previous ovarian surgery. So, ideally, in a recurrent case, surgery should not be the choice. She should head straight for IVF if she has not conceived. So, when you come to IVF and endometriosis, which protocol is ideal? The protocol which agonist and antagonist can be used. The best part is that IVF stimulation for IVF does not cause progression of the disease or recurrence of the disease. So it depends on the comfort level if you can use a long agonist protocol or the antagonist protocol. The latest is a progesterone primed ovarian stimulation, because that is a protocol where you use medroxyprogesterone 10 milligrams per day from day 2 of the stimulation. And this actually takes care if the patient has pain, it reduces the pain, and plus, of course, the cost. And remember that in endometriosis patient, the risk of infection is low, but it is there, it's 0.2%. And to avoid this, what we can do is give a broad spectrum antibiotic. And by chance, if you puncture the endometrioma, please avoid contamination of the eggs with the endometrioma fluid, and also give her 24 to 48 hours of IV antibiotics. Which technology is better, IVF or ICSI? IVF has given equally good results, and more studies are needed to actually prove that ICSI is useful or is better than IVF. So, what are the different ways in which you can improve the success rate? What are the different ways in which you can improve the pregnancy rates in ART in women with endometriosis? A GnRH analog pretreatment. The GnRH analog pretreatment with aromatase inhibitor studies have shown improved live birth rate. Oral contraceptive pretreatment, dopamine agonist pretreatment, and of course, we follow it by a frozen thawed embryo transfer. What we are using in the lab is artificial intelligence for predicting future pregnancy, especially in cases who are undergoing vitrification and also in cases where IVF is being done. And this is a study published in Jan 2024 where 482 patients of single embryo transfer were taken, and higher AI score was significantly associated with a live birth rate. And so AI was significantly associated with a higher live birth rate probability. Also, AI can be enhanced. AI can be used to deselect embryos with poor pregnancy outcomes. So artificial intelligence in the lab, especially in these patients, is really useful. Elective embryo freezing, that is what is recommended, because then we can, freeze the embryos, treat the patient pre-treatment with GnRH analogs, and then do the frozen thaw embryo transfer. So meta-analysis of 3,000 women showed a higher live birth rate with frozen thaw embryo transfer. The microbiome is another new kid on the block. Infected bacteria, especially in this study, there was E. coli, which was seen in the uterine microbiome. And infected bacteria attract macrophages to the surrounding microenvironment. These produce TGF, and TGF causes endometrial fibroblasts to transform into fibroblasts. These phenotypic transformations, especially adhesions, etc., induce endometriotic lesions. So this is another way where we can give broad spectrum antibiotics to the patient. Ethanol sclerotherapy for endometriosis. Is it ready for prime time? This was a technology which was there for a long time, but are we ready to do it? This was a beautiful article by Susan in Jan 21, Fertility Sterility, where she's given the 10 basic steps. Remember, you can do this with ethanol. Keep the ethanol for 10 minutes, but the patient should not move during the ethanol step so that there is no spillage of the ethanol. And to prevent infection, vaginal swabs are done 1 week prior, and a prophylactic antibiotic be given. But you should not do this for all patients. Ideal patients to include are poor surgical candidates, the decreased ovarian reserve, and previous surgery with decreased ovarian reserve. So this was an article Gone with the Wind by Pertia in 2022, I think. And this article actually said that the success rate of the patients with endometriosis and without endometriosis following IVF are similar. So this was, of course, based on the Bishop's study, which actually showed that the euploid embryos are equal and the live birth rates are equal. But it is because of the advances that we are seeing today. Those are the GnRH analog, which is given, the medias which are available today, culture techniques, benchtop incubators, poloscope, male factor, if there is, we use MAC, MC, etc., the embryoscope, the NICS, and improved embryo transfer technique. All these definitely, and now to add to it, artificial intelligence. So all these advances in the lab has really helped us give very good results in endometriosis patients. So I would like to conclude my talk by saying early diagnosis is the key. Role of pre-ART suppressive therapy. There are a lot of studies which are going on, which will actually, we'll get the results in a couple of months, and we will know for sure that these are the ones which really work. Fertility preservation should be offered to patients of endometriosis if they don't want to have a child soon. And frozen embryo transfer has definitely given better results in these patients. Thank you very much.